Good afternoon, CASCA members. My name is Simon Schwartz, and I'm here today with our Executive Director, Chris Scoggin, with the Colorado ASC Association. And we want to welcome you to one of our first webinars of the year. It's our second technically, but we're first quarter. So we want to welcome everybody today to our webinar, where we'll be hearing from one of our corporate members and Sapphire sponsors and industry experts, Pinnacle Healthcare Consulting. But before we get to that, I want to remind our viewers and our participants to utilize the chat feature for any questions you may have. In addition, we are happy to pass along any questions you may have to our presenters directly if you don't want to utilize this. The last item I want to bring up is we're very excited about our 2025 Infection Prevention Summit, which is happening Thursday, February 27th. That's this Thursday. That's tomorrow. For those of you watching right now, we're very excited. We have a sold out crowd, over 60 participants for the event. And we just appreciate you as members taking advantage of these resources, both our in-person and our virtual. CASCA has a very busy and spend hours talking about our legislative and regulatory efforts. I want to pass it over to our Executive Director, Chris Scoggin, who will not only give a quick background of that, but also introduce our experts today for our presentation.
Thank you, Simon. Again, I want to emphasize my appreciation for Pinnacle Healthcare Consulting as a corporate member and a Sapphire sponsor. This is the livelihood for our organization, so truly appreciate the support and ongoing expertise. I'll go ahead and pass it off. We have Curtis Bernstein and Jana Sizemore. I'll let you guys do a little self-introduction for a moment, and then I'll ask the first question. So Curtis, would you like to introduce yourself?
Yeah, thanks, Chris. Yeah, Curtis Bernstein, I'm a partner with Pinnacle Healthcare Consulting. I help run our business valuation, financial due diligence, real estate, marketing, and other groups within the organizations. I started out originally within health systems and then broke out to ancillary service providers in the accounting and operations side before joining the consulting world almost 20 years ago, and have been working on, as I said, valuation and financial due diligence and real estate and stuff like that for almost 20 years now. Jana.
Thanks, Curtis. Hi, I'm Jana Sizemore, Senior Manager with Pinnacle, and I have 15 years of experience in the industry valuing different business entities and also working on provider type arrangements. So real excited to talk to everyone today about ASCs.
Well, thank you, Curtis and Jana. Well, again, we have a wide variety of corporate members that are involved to help support ASC facilities throughout the state. Curtis, I was wondering if you could tell us a little bit more about Pinnacle Healthcare Consulting and kind of more of what you guys do.
Sure, Jen, do you want to advance the slides? So Pinnacle Healthcare Consulting is a group of a number of different companies, including Pinnacle Enterprise Risk Consulting Services, which does compliance and coding reviews and chart reviews and internal audit and all the stuff associated with the risk side of the business. Then we have Pinnacle Healthcare Consulting, which Jana and I generally sit under, which has to do with valuation, transactional support services, the analytics. We also do strategy services. We do value-based care consulting, a number of other different issues and concerns on the provider side for both Pinnacle Enterprise Risk Compliance Services and Pinnacle Healthcare Consulting. We also have Pinnacle Healthcare Revenue Solutions, which is our rev cycle company. We do front to back revenue cycle. So we do everything collecting, denials management, everything in that area. We have a couple other unique companies also within our group, MRC Global, which may not touch upon this, but you never know, it may come up in your work, but it's a life science company, does compliance in life sciences, 510K, FDA clearance, and stuff like that. And then Telenef is a telehealth company, which actually helps provide nephrology services to rural markets, to jails, for example, and other provider services around the country. Works hand in hand with physician practices, nurses on the ground, and other operational support. as a Pinnacle has grown throughout the years, we have about 300 people now. We just try to bring the best people to help out. If you ever have an issue that comes up and you say, this is a concern of mine, if you need to manage risk, if you need to improve performance or create any kind of innovative solutions, we have the people that have the experience to help you do that. And we've been very successful with our clients in those areas. Together, all these groups, the companies, the service lines, they all work as one. They all go hand in hand if something overlaps into another area. All the people work together to create the right solution for our clients. If it's just small little, business valuation for just your center, or it's, hey, we need to syndicate to new doctors. We need to figure out new real estate alternatives for our center. All that, it can all kind of go together, and all our professionals can work together to help you with that.
So Curtis, sorry to interrupt, but just a question, because you and I have known each other for 20 some odd years, and you've really been a resident expert in the area of valuation, but it sounds like the evolution of PHC and the entities involved, you've really evolved to be somewhat of a one-stop shop in these arenas. Would that be a correct assumption?
Yeah, I mean, that's what we're definitely trying to be. We're trying to bring the right people to the table and to be able to help our clients meet their needs as a one-stop shop with high quality work to help them achieve their goals.
It's interesting that you brought up beforehand, how you're changing, how your pathway is moving to the industry. And it makes me think of a word that we all hear and we all know, which are trends, right? What are we seeing trending in the industry? I wonder, based in Colorado and kind of having a network that spans the country, we're seeing some significant trends, whether it's MSOs, their engagement from a policy side. We're seeing legislation related to private equity play a role. We're seeing it within the industry. Recruiting of physicians can be difficult, or getting anesthesia in the ASC can be difficult. So considering both you and Jana spend a lot of time looking at valuing these ASCs, not just these other services, what are current, and maybe Jana, I'll throw this one to you since Curtis gave a little bit of background. What are some of the trends that you're seeing in the ASC space? What are you seeing that's impacting revenue? What are you seeing that's impacting business flow? And I would say on the last part, what are you seeing considering the value of these ASCs to the general healthcare market and the business market in Colorado?
Thanks for your question, Simon. Some of the trends that we're seeing within the ASC industry is that transaction volume continues to grow, seeing 3% at major centers as more and more procedures continue to shift to the outpatient setting. The most common specialties in ASCs that we see are orthopedics and advanced spine procedures. Cardiology is also a fast-growing specialty in this space, with more to come on that, because those cardiology procedures are currently allowed in certain states such as Pennsylvania. Yet to see that in the Colorado market, though. Other specialties where we're seeing a shift to more of the outpatient setting include ophthalmology, dermatology, and low acuity specialties. Every year we look to see what CMS indicates what new procedures are permitted in the outpatient setting. And for 2025, we see that there's a focus on dental procedures and regenerative therapy. Because ASCs are allowed to perform a limited number of procedures on Medicare patients, we always look to this because HOPDs are allowed to perform a longer list of procedures. So it's beneficial to see when more Medicare beneficiaries are permitted to do procedures in the outpatient setting. As you mentioned, we are seeing the cost of anesthesia providers increase as Medicare and private payers push on their reimbursement rates. So we're seeing stronger demands from anesthesia partners for different centers.
And if I could just jump in real quick, obviously there's a strong competition between hospitals and surgery centers for anesthesiology. And with the shortage of anesthesiologists nationwide, we are hearing a lot of that in the ASC space, the challenge of getting anesthesiologists to cover the surgery centers. And obviously, there may be a detriment on some surgery centers to be even able to open and increase their capacity on certain days without the anesthesia coverage. So we obviously continue to see that demand is high for anesthesia. We're seeing the pressure. We do a lot of work on the hospital side, obviously increased compensation and competition with hospitals is pushing anesthesia to a point where it needs to continue to be affordable. If revenue is going to be lower for surgery centers, you need to obviously manage costs, and with anesthesia costs going up, that's going to eat into any kind of bottom line of a surgery center. So definitely challenging and complication for our surgery center providers and our clients.
Curtis, I'd love to hear your perspective related to the physician side of trending of what's going on in the industry. Both of you work in a number of different places, but specifically, Curtis, I know some of the markets that you work in, and I'm just wondering if you're seeing similar trends in those markets as you are in Colorado when it comes to surgeon interest in investment, surgeon interest in building, surgeon interest in buying points into facilities. Trending, what we're seeing is, everyone's trying to figure out how to find these physicians. I'm just wondering if that's something that you take into consideration with trends happening nationally and locally.
Mm-hmm. Yeah, I mean, obviously, a lot of physicians already locked into surgery center joint ventures. There was a recent OIG, Office of the Inspector General opinion, that said that they feel comfortable allowing employed physicians to have ownership in surgery centers. So that's becoming a little bit more of a trend on the hospital and health system side, which obviously pushes more for a joint venture with hospital and health systems because they are employing the physicians in a lot of cases, whether it's the orthopedic surgeons or the gastroenterologists or the pain management physicians. They're employing them and they're allowing them now to have an ownership interest, which obviously then comes into Stark, which Stark hasn't really had a part in surgery centers because ambulatory surgery hasn't been a designated health service under Stark, so you only had to deal with the anti-kickback. But once you start getting into including ownership and compensation, then you have an aggregate compensation issue under Stark. But there's definitely been more of a push there to try to get those physicians and surgeons involved in the surgery centers and move the cases out into the ambulatory surgery center. I think there's still a lot of interest. There's been obviously movement within current joint ventures as well, where physicians have ownership and they're questioning, do I want to work with this management company? What are they providing to me? And, we're seeing some of those break apart and then creating other opportunities as well. Obviously, there's non-compete issues and some of that with current operating agreements and how they're working. We're seeing buyouts of those non-competes as valuation. What is the value of the non-compete and how do we buy our way out before it gets into any kind of litigation session? So yeah, I mean, I think there's interest. It's obviously compensation to the doctors, and they want to be involved in a successful center because it has to make earnings and make cash flow for them to earn compensation. So there's doctors that are looking at ways to move around their current joint ventures and also work in other settings like within hospitals and be involved in the surgery centers that are owned by the hospitals. And some of those are also joint ventured with management companies. So it could be hospital, management company, and doctor as well.
Yeah, there's definitely a lot of different mixtures of how this ownership structure works. Last little tidbit related to this element, and Jen, I'd like to pass it your way. And I guess this question isn't a pro or a con, but from a trending perspective, what do you see with private equity in relation to the valuation of ASCs and that party that's going on? Legislatively, we're seeing different things happening all over the country. Anything from not touching it at all to trying to expel it from the state. So I'd love to kind of just gauge kind of where your perspective is when it comes to private equity, because they play a role in ownership of these facilities across.
Yeah. I mean, from our perspective, obviously, we have a new administration in the White House, which is probably more private equity friendly. So you know, personally, I think for the next at least 4 years, we'll start seeing more favorable actions from the federal government as far as trying to kick out private equity. Obviously, there's different states that are pushing private equity with California and Oregon and stuff like that. I don't know where we'll go on the state level. The attorney general, some states are requiring transactions to run through the attorney general's office for approval and making sure things happen, like in Connecticut. But I think, you know, obviously at the end of the day, private equity has a strong interest here. The doctors have a strong interest, I think, in working with private equity because obviously the more demand, more cash that's in the market drives up value from that perspective, and they're trying to maximize their earnings. Everyone's obviously trying to maximize the earnings of the center. And it's obviously money that can go in to help grow the center, whether it's capital expenditures or it's marketing or whatever needs to happen for those centers to get out there and continue to grow their revenue is a means for them to try to work with private equity. And then it's up to private equity, like I said earlier, to kind of continue to prove their worth to the center. That's obviously been a little bit of the struggle. Is, you know, a lot of physicians say, well, we could just do this without you. And you know, then there's the question of can they? Obviously, there's a lot of synergies with companies as we have listed here, and Jan will get to this, but like the USPIs, the AmSurges, the SCAs, the surgery partners that, you know, run a lot of centers, see a lot of stuff, can help leverage, you know, are obviously seeing a lot of leverage of managed care contracts on certain level with some of these companies, which can also drive more revenue, help support CapEx and the growing cost of anesthesia and nursing and stuff like that. So, you know, if the PE-backed management companies can provide some of that support, obviously it's beneficial to the centers. And I know the PE firms want to be in this space because obviously there's a push for more cases to go this way, and there's decent earnings, profit percentiles and stuff like that that'll drive cash flow to private equity companies.
Jana, do you have anything to follow that up with?
Sure, we're seeing that there's definitely an increase in the number of ASCs. As you can see in the chart on the screen, there's been quite a growth from 2019 to 2024. And currently there are 146 licensed and certified ASCs within our home state of Colorado. And nationwide, there are over 6,300. So we're going to continue to see growth in this space. And for many of the reasons that we've already mentioned, there are expectations for the revenue to also increase. And here you can see that there's strong growth in various specialties. The market's projected to grow to about $55 billion by 2029. And beyond, as more procedures become available for minimally invasive procedures to shift from the inpatient setting to the outpatient setting.
That makes a lot of sense, and I think, you know, this really sets up for. I don't want to skip over. So please.
Sorry. According to the Ambulatory Surgery Center Association, some of the fastest growing specialties that we continue to see are so cardiovascular and GI. And again, a lot of Medicare expenditure is in the GI and ophthalmology space. And we're going to continue to see the rise in procedures. So it's very exciting for physician investors in this space and our ambulatory surgery center friends.
Absolutely. You know, I can tell you that, you know, 20 years ago, the conversation was, how do we prepare for the baby boomer generation, right? How do we prepare for this onslaught of patients? And we're there now, right? We're at this place where there's enough patients, but now it's about providers and filling the schedule and anesthesia. So I think, you know, this brings me to my next kind of set of questions and what I would consider the meat of the subject matter that we're talking about today, which is, you know, what are the factors that are in consideration when valuing a surgery center? And I think why is that important is that this isn't a cookie cutter, right? These facilities, these brick and mortars are designed for or organized in a number of different ways. You mentioned it before, you have large MSOs, independent facilities, you have single specialty, you have multi-specialties, you have facilities that are developed with the interest of a physician with unique building characteristics. So I just wonder, considering all the different variables that play into a surgery center, how do you even start with those factors when you're looking at the value of the facility?
So we look at value drivers and here we got 5 buckets: case volume, reimbursement, capital expenditures, personnel and supply expense, and then competition within the market. So for case volume, if you're looking to sell interest to other physician owners, there's obviously a base of cases that have been done at the center historically. And there's a trend that, we're going to look at, whether it's upwards or downwards or flat. And then we're going to say, well, what is the capacity within the center and how much more cases can the center do? And if you're selling out to a physician that's not an owner, obviously they're going to bring more cases that they've done historically, but they're not going to want to pay for that. So really, you're going to give up some historical distributions, but hopefully, when new physician brings in more cases, there's certain fixed costs and variable costs, as we all know, and hopefully the new cases, may not even increase all the variable costs because you may have the staff, for example, the nursing staff, to handle a certain amount of the case volume as well. So there may be some synergies there. Ultimately, that'll drive more cash flow and earnings to the bottom line. And so it should be kind of a win-win for everybody as you bring in new physicians, but that doesn't ultimately mean that the value of the shares are going to just increase pre-deal because there's no guarantee the physicians will buy in. Continued recruitment, as Simon was saying, baby boomers, people are getting older. It's not just the patients, it's also the physicians, right? So you need to look at what is the exit planning that's being done, not just at the surgery center level, but also at kind of the practice level. A lot of times people have brought in new partners, younger partners, or maybe there just is no plan. And the question is, what happens to that case volume? And what does that mean for the center going forward? And how does it ultimately affect value? Obviously, if those cases go away, it's going to lower value. There, as I just mentioned, there may be some variable costs that can be decreased within the center, but then there's a lot of fixed costs, like the overall space. The center's not going to get smaller just because the patients aren't there. If you have 3 ORs and you're using all 3 ORs, and then patients go away, maybe you're operating 2 ORs, but that 3rd OR is still there. So, that cost is there, and it doesn't ultimately reduce cost as much. Obviously, there's still that cost there. But you can also recruit new specialties, as Jana said earlier. Obviously, orthopedics is big within surgery centers, and complementary to that, we see a lot of GI or pain. So if you have an orthopedic center, you may look at adding GI and pain. And the question is, what is those opportunities in the market? And that kind of gets down to the overall specialization of the center. Obviously, there's efficiencies being a single center. We see a lot of GI centers or ophthalmology centers that are killing it. You're doing a ton of cases in non-sterile procedure rooms. You could do a smaller type of center, and you just keep churning those cases, and obviously can create a lot of potential cash flow there. And obviously that drives a lot of value. Next, after case volume, we look at reimbursement. And what's going on with the payer mix? What are your patients? What kind of insurance does your patient have? So for example, a lot of Medicare cases with your ophthalmology, your GI, your orthopedics. Obviously, then the future value of the company relies heavily on what Medicare is doing. You may, if you're doing orthopedics, there may be a good amount more managed care as well, depending on your mix. And then we have to look out at what's going on with the overall market for those specialties and what the insurance companies are doing. Obviously, the big buzzword has always kind of been value-based care the last few years. And surgery centers really haven't been that involved in value-based care, but it'd be interesting. It seems like everyone says that's here to stay. The managed care insurance companies are saying that's here to stay, and they're looking at ways to work with all the parties. And then the question is, once that starts happening, how does the surgery center industry fall into that, and what does that mean from a reimbursement model and ultimately revenue? Look at contract negotiations. How often are your contracts updated, your charges and your claims? And then how is everything managed, your denial and claims management, stuff like that. In fair market value, we talk about a hypothetical willing buyer seller. If you're trying to sell a controlling interest, let's say to a health system or to a management company, like a PE-backed management company or non-PE-backed management company. And we're looking at what ultimately, from the willing buyer perspective, what can the market achieve? What happens to reimbursement? Does the market have better contracts? A lot of times if you have a small surgery center owned by a couple of physicians, they're not really skilled in contract negotiations. Some may be, some aren't. But if you're not, then you may be leaving money on the table. So from the hypothetical buyer, we're going to look and say, okay, if you're getting X per case, maybe the market pays Y per case, and how do we adjust for that in the overall value? And that's the story you need to understand from the valuation perspective. And as you're getting ready, to prepare a surgery center for sale, if that's the route you're going. Next, capital expenditures. Jan, do you want to take that?
Sure. As we mentioned earlier, when we're transitioning physicians, perhaps if you have a retiring physician looking to bring on new physician investors, it's one thing if you continue with that same specialty, and it's another operational aspect if you switch out specialties, introduce a new one. So there might be the idea that you have to invest capital for the build out of new ORs, additional ORs, or to go back and repurpose the existing ORs for that new specialty. And then obviously, if you're introducing the new specialty, you have to have the specialized equipment that's appropriate for it. And this always brings up capacity constraints, and capacity constraints can look like, is it physical capacity that is limiting the number of ORs and putting pressure on utilization? And it can also be from the perspective of personnel. Do you have the right nursing staff, et cetera, to support that volume? So that takes us into the idea that personnel and supplies expense are huge impacts to the value of an ASC, because these are two of the most significant expenses from an operating perspective. And we always ask detailed questions, particularly related to these when we value a surgery center, because we need to understand if there has been, for example, an uptick in the usage of contract labor, because we do see that there's a competition between hospitals and ASCs, not only for the physician talent, but also the nursing staff talent and so forth. And then, as we mentioned earlier, we are seeing a lot of pressure from the anesthesia groups because their cost to recruit and retain anesthesiologists, CRNAs to help support the ASCs is it continues to increase. And so we've seen a lot of instances where earnings are impacted quite significantly by an increase in the subsidy that's required for the anesthesiology group that supports the ASC. And then we're also seeing huge increases in supplies expense. And so a lot of ASC administrators are spending a lot of time at the negotiation table, not only with payers, commercial payers, as Curtis mentioned earlier, but also the supplies vendors.
On the anesthesia side, just real quick, Jana, we're seeing now, we do a lot of analysis around anesthesia subsidies, both hospital and surgery center space. And I saw a stat the other day that there's more CRNAs now than anesthesiologists, about 5,000 CRNAs versus about 4,600 anesthesiologists. And we're starting to see the cost of the CRNAs increase. We've seen a huge increase, probably about 250,000 a year for a CRNA and almost $350,000 a year for a CRNA now across the country. So we're starting to see that, and we don't see that in a lot of the benchmark surveys yet either. If you're looking at like an MGMA benchmark survey for providers, I don't know that it's completely keeping up with the times. Obviously, that's all a couple years old. I mean, if you're buying the 2024 surveys available now for all the providers, they're based on 2023 data, and we're at 2025. So you're a couple years behind now looking at that information as well. So just make sure you're aware of that as you're trying to think of what to do with anesthesia.
We're seeing similar trends, as you mentioned. We're hearing similar things from our providers and some of the third-party anesthesia providers that are intergrained with CASCA. It's funny in hearing, maybe funny, haha, but funny, interesting. Jana, the things that you brought up just beforehand as you're going through kind of these checklist items, it almost made me think of Carfax, right? Know your car before you buy it. Understand the history of the car before you buy it. And I don't mean to dumb it down so much, but the reality of the situation is that these physicians or these MSOs, whoever the owning parties, are looking to do whatever they're doing. It's almost a similar approach of really doing or working with somebody or doing the due diligence to really know the history of not only the facility, but the providers that are engaged with it. Would you say that's correct?
Yes, absolutely. And we always take the perspective of asking what has taken place historically, and then what's also expected to, what type of volume is expected on a go-forward basis. Every single center that we value is unique, and they all have unique markets in which they operate. So we ask questions and want to understand, what does that competition look like? Competition, historically has been from hospitals or other surgery centers, whether they be multi-specialty or single specialty or extension of practice in an office-based lab setting. And many of these centers, if they're competing against the likes of those, they have extra costs. And we have seen marketing costs increase over the past couple of years as well, not so much to the extent of growth in operating expenses such as supplies, but we have seen increased marketing campaigns, even in the digital marketing space. So there are more and more ways to reach the patient base to contribute to volume.
And Jana, I feel like I'm seeing less clinical co-management going on and being competition. I think there was a point where if physicians were tied into a surgery center, they had a non-compete from an operating agreement that prevented them from owning an interest in a competing surgery center. And hospitals and health systems would set up a clinical co-management, which didn't conflict, I guess, with the non-compete because it wasn't actually ownership in any type of surgery center type model. I mean, they still exist. I'm not saying that they've fallen off, that people aren't doing them. I'm just not seeing as much new clinical co-management going on that can be, I guess, considered competition in a sense for surgery centers. I'm seeing a lot more hospitals and health systems jumping into the surgery center space. We've had a lot of conversations recently, like 5 new health systems that haven't had a surgery center strategy in the past. And now they're like, hey, let's do this, which gets a little bit late to the market, but it's still out there. It's still happening.
Well, and I would just follow up that, 10, 15 years ago, the idea of a hospital investing in the surgery center in that way wasn't even kind of part of the conversation. So definitely the market change is pretty consistent.
Yeah. I tell a story. When I first worked at my first hospital in the mid-90s, we built a surgery center. The CEO liked the idea of surgery centers. We built one. There was no physician ownership, and as a result, there were no cases. So it was just an empty surgery center back then because the physicians were not involved really with the health system on that level. And yeah, it's definitely different here almost 30 years later.
Amazing. Well, definitely appreciate it. Jana, I would love to hear a little bit more about, if you want to go back real quick, because you hit some factors, but definitely want to hear more about competition, if you don't mind. I think you chatted a little bit about the marketing element. Do you mind just spending a tiny bit more time about that value of an ASC having that element? Because as small businesses, some of the facilities are connected with a whole team in that realm. And then I just left the surgery center that, the administrator plays all those roles and it's not connected with the big MSO. So just kind of love to hear where value plays a role in those two arenas.
Sure, marketing is very important, and I'm actually going to skip ahead to one of the case studies that we wanted to highlight with you today, and it has to do with a multi-specialty ASC that we valued that's located in a fun area, mountain destination, and it's the form of ownership is a joint venture with physicians, and they market themselves not only to the local area, but also they have a like a medical tourism program, which has attracted out of state patients. And so that has really been a unique way in which they have marketed it to potential patients. And, in that case, they have a strong resulting payer mix that presented a bit of a challenge when you're talking about the reason we valued it was for the exit of one physician investor and then to attract new investors. And so it was a fun way to go through a project and had to strike a balance between, one party obviously wanted a higher value and another person wanted a lower value. So there was a lot to consider in that valuation. And then another one that we value talking about marketing, but it's kind of in a different light, is a multi-specialty ambulatory surgery center that was entirely physician owned. And one of the specialties included bariatrics. And the volume, about 1/5 of the volume was bariatric surgery procedures. And it was so interesting to see that their volume had dropped off because of the introduction of the GLP-1 drugs. And so here, when we talk about competition, it wasn't necessarily from another ASC, but rather from almost like a substitute product, if you will. So weight loss can take form of the surgery or can take form of a drug that can help the patient. And so the result of that valuation was pretty keen because what they did was they tried to have an uptick in the volume done by orthopedics or by orthopedic surgeons. And so we helped them to calculate the value of an ownership share so that they could attract more orthopedic surgeons to try to, keep utilization at a similar level as they had historically to make up for that loss in bariatric volume.
It's very interesting information. And I think it clearly spells out, how do things play out in actual valuations, one compared to the other. And those case studies really help provide some context to it. There's one question I have, and I think it relates to both your case studies you provided, but also to factors when valuing ASC, and we haven't really touched on it. And I'd like to hear both of your perspectives because, one of you has 15 years of experience in the industry. The other has more than that, but all dealing with different individuals. How does reputation play a role within valuation? I think we've got a few different players, and these are variables within these valuations, but you have MSOs, you have physicians, you have Google review. How does reputation of both the surgeon, the facility, the staff that are involved, how does that play a role when evaluating the ASC?
I'll start. Obviously, there's always the financial aspect of anything. So reputation drives cases, right? I mean, people refer cases to orthopedic surgeons, to gastroenterologists, to everybody, to ophthalmologists. And for a patient to go to that ophthalmologist, the better the reputation, obviously, the more likely the patient is going to decide to go to that physician, which is going to drive the volume to the center. And as you mentioned, Simon, obviously, now not only do you have your reputation with other physicians, and obviously that reputation could be tainted. You could be golf buddies, you could be drinking buddies, you could be your family members could all be best friends, and you may not be the best doctor, but someone will refer to you for other reasons other than your ability to provide great surgery, and have a good bedside manner. But obviously now with the internet, that changes that game a little bit, because patients can be out there looking at those things. So before, you had to have those relationships closer with other doctors. Now you also need to have a better online presence that shows that you're a good doctor all around, and obviously that drives that value through caseload. Value-based care, as I mentioned earlier, could potentially drive payer contracting rates and ultimately revenue through higher reimbursements. That hasn't happened yet. Obviously, we're still on a fee-for-service type basis, both nationally and in the state. And so, obviously, as we move more toward that model, then the higher quality physicians, should make more money through revenue, whether it's some kind of shared savings model or value-based care bonuses or anything like that. We just haven't obviously seen that yet.
It's very interesting that you asked about the reputation, because a story behind the case study that we have up here about an ASC located in the Southwest that's single specialty, and they're looking to bring on surgical specialists from spine and pain management to expand their service offerings. They did, in our interview with them, they mentioned how important reputation is and word of mouth, because their idea to grow their surgery center is that they want to create ownership structure in which they can successfully attract new physician investors, but they want to maintain a top class center with, very good patient outcomes and patient safety, so that they can have that word of mouth spread from the initial physician investor, and then in the next year attract more and more, because they do have quite a goal of expanding, not only from the existing 2 OR that they operate, but to grow into a larger ASC setting as well. So reputation matters from the physician to physician peer relationship as well.
Yeah, the struggle you get into, and we're seeing actually a lot of this nationally, is with good centers with strong reputations, with the more doctors, the larger centers, they grow to be very large and they spit off a lot of cash flow. And then the question is, when you try to bring in new physician investors, how you keep that rate consistent with market to some extent, because physicians think, I can go down the street and buy an interest in the surgery center down the street for $40,000 per 1%. And you want to charge me $120,000 per 1%. Of course, the $120,000 per 1% is paying back distributions equivalent of the $40,000, right? I mean, if you say $40,000, you get $25,000 a year in distributions, and you get $100,000 100,000, 120,000, and you get $75,000 a year in distribution. So percent wise, it's still the same, but then the physicians, and especially younger physicians, they're new,
Perception.
they have medical school debt, right, that they're paying. Maybe they relocated, they have expenses, they just bought a house and a nice car because they're a doctor, and now they're saying, well, now I got to shell out 120,000. That's obviously a lot of money. And so that's the question is, how do you do that? And to Jan's point, obviously there's different share percents, or you can sell less of a percent. Obviously, some of the challenges are, as you mentioned, Simon, you have baby boomers. And so you have a doctor that's been a surgery center owner there, has 2%, and now they want to get out, right? And now you need to say, okay, well, who do I sell that 2% to? And maybe back to the PE thing, the PE company may be willing to buy that 2% add to their percent, but then the question is, do you really want them owning 55, 60% PE, or you still want it? You obviously want to bring in the more physicians. So if you find the physician to get that to the 2%, obviously that's the better scenario for the center, because the physicians obviously do the surgeries, which drive the revenue and the cash flow. So the question is, how do you do that if the value of those shares are that high? And there's obviously ways to go around that, as like that last case study had pointed to one way.
Do you all find yourselves being mediators in a way sometimes, if there are deals that, and I don't want to end on a negative, we're getting towards the end of our hour, but I don't want to end on a negative, but we've talked kind of about these perfect scenarios when the case volume is right and finding the right people. Would love to just hear, because y'all are experts in valuation, how do you handle the situation when deals are falling apart? How do you maintain your position as that third party assist if things aren't going the positive way, whether it's with physician practices, the MSOs, whoever's in the dealings of the situation? I'd love to hear kind of how you position yourselves in those situations.
Yeah.
Or if you do.
Obviously, we've done this for a number of years, and I think communication obviously is very important, how things are communicated. So we're always trying to mentor our clients on how to best communicate certain things to physicians, like you said, or like I just said, the 120,000 versus 40,000. How does that work? Obviously, there's other issues that are beyond the valuation, which may be a case in those kind of deals. We do have a strategy group, as I mentioned earlier, that syndicates centers and does those negotiations and helps with contracts and stuff like that. So, they could obviously get involved as necessary. A lot of times we're helping run that from the very beginning. But at the end of the day, there's always other issues than just money that may come into play that don't always affect the valuation. But from the valuation perspective, we have certain standards we have to follow, obviously, in credentials that we have. And so we try to do our best to support a number that makes sense, that supports the expected rate of return. The Office of the Inspector, the Department of Justice, really pushed on rates of return for investments too when physicians are involved. So we need to obviously consider that in our valuation as well. Like, you can't pay the $40,000 for the center that's spending off $100,000 a year for that 1%, because it's such a big center. You can't triple your money in 1 year. That obviously is bad facts. So we try to obviously look at how we can communicate that the best way possible and work with our client to help them. We have been involved in cases and talking to both parties. We've been engaged by both parties too, where maybe the center just engages, or if it's a health system and physicians trying to do a joint venture, we'll be engaged by the health system and the physicians. Obviously, it's a little bit more complicated, as Jana said. Every party, one wants it higher, one wants it lower, depending on the situation. And we need to make sure we're communicating. Like, we can't communicate with the health system without the physicians on the phone. We can't communicate with the physicians without the health system on the phone, and they get frustrated sometimes with those scenarios. But if that's how we're engaged, that's how we're engaged. And then sometimes it's just political, and we'll always have those conversations. in whichever way they want to have it. I mean, we can be engaged by the health system, but we're still going over the draft of the valuation with the physicians beforehand, because the health system says, hey, let's do that, let's have that process so that they feel more comfortable with the process.
Absolutely. Jenna, would love to hear kind of your experience in the worst case scenario book, and how you manage your interactions with the facilities and the different individuals that are involved.
Yes, I would echo what Curtis said is the most important is communication. And in, I guess, the worst case scenario, if you want to call it that I've participated in, transparency was the key term here. And being transparent doesn't necessarily always mean that you're opening up all of your general ledger detail to show one party or the other, but you're trying to create that story behind the numbers of why volume increase, decrease, why certain expenses are so extraordinary, or why somebody's not getting the block time that they think that they deserve, or that they absolutely do need to continue to grow their practice and their volume. So going back to point that Curtis made, when we're dealing with both parties, one obviously wants a lower number, one wants a higher number. And so if we don't make either party happy, we're actually doing our job, because we're coming up with what is perceived to be the most perceived appropriate opinion of value for an interest in that surgery center. So to answer your question, I think that, to echo off of communication and that level of transparency is so key.
Also,
Well, yeah.
just real quick, I mean, it's also common in the valuation space, I'll just throw this out there for the listeners, that they may get competing valuations. I know from the government perspective, they don't want kind of shopping for valuations, but I don't know that that's really shopping. We do see it a lot where the physicians may get a valuation and the hospital may get a valuation, for example. And you hope they're kind of close. And if they're not close, sometimes they get a third valuation, agreed upon by the parties, and hopefully, you kind of work in, like Jana said, someone's bound to not be happy in any kind of negotiation for some reason. But hopefully, if you have enough data points, you can say, hey, look, we went through this process. It was a good process. And these are the results, and we're gonna hopefully live with them.
Amazing. It's really great to hear. I really want to use this last couple of minutes to open up. I have one question that's come through, but want to leave any last statements related to evaluations, because the question that came through relates to when will we see you next? And I've got a couple things to plug in related to that. But if you're going to be at any Becker conferences, ASCA, we'll plan to say that. But is there anything before we close this out? It's been a little bit of a fire hydrant of information. So I would definitely suggest to our members that are listening, maybe watching this at their leisure, if your facility, your MSO, your company, your doctors are looking, we want to suggest you reach out to our resident experts here at Pinnacle Healthcare Consulting. And with that, I want to hand it off to y'all for any last statements before our final question.
Yeah, I think the question is where else are we going to be? Well, obviously ASCA's in Denver this year, so we're pretty excited. We'll be there with the booth. I think I'm presenting. Right now, I'm scheduled to present at Becker's in October as well, so we'll be there as well.
Amazing.
And then later in November, we'll also be at the Colorado ASC meeting in November. So we'll see you there as well.
You did my job, Jana, for me. I really appreciate it. We're looking forward to y'all participating on our trends in the industry, marketplace, everything that relates to the ASC industry in Colorado. Pinnacle Healthcare Consulting will be joining our legal team, William Lardner, and then we'll have a third party on there as well. It's not on the top of my mind right now, to help give that overview of the state of the industry in Colorado. So we really appreciate your insights. For those people that are going to ASCA, I believe I will be presenting. Chris will probably be involved in State Association Leader Day. Jana will be walking around. It's in our backyard, so we highly encourage you to participate at ASCA. I have nothing but positive things to say about Becker's meetings in Chicago. Not only a great place to visit, but the content that comes out is fantastic. So Chris and I just really want to thank Pinnacle Healthcare Consulting and all the other subsidiaries involved. One thing I would just say to our CASCA members is that with the revenue cycle arm being a newer arm, definitely inquire and ask the team about it. I would just say in the world of competition and capitalism, you never know if you're going to get a better deal unless they ask. So with that, I just want to thank everybody for their time today, their expertise. We look forward to your participation. And the only other housekeeping item I do want to mention, and PHC may be interested in getting involved, is our Western Slope celebration called Elevate and Thrive. We have secured the week of June 23rd, I believe that's the Monday, where we'll be putting on a mini conference event on the Western Slope. And we hope to bring those corporate members that do business out there to talk with the facilities on the Western Slope. So Curtis, Jana, can't thank you both enough for your support, your involvement with the association, with your longevity of involvement with the industry, and just all the different areas that y'all support at. So thank you both so much. We look forward to more information coming in November and before then at the different industry events nationally.
Good, we
Thank
appreciate
you both.
it. Thank you.
All right, we hope everyone has a great rest of the day. And we look forward to seeing you at the Infection Prevention Seminar on Thursday. Have a great day, y'all. Bye-bye.